Hello and welcome to the Industry Innovations podcast of the National Lipid Association. This podcast is sponsored by Arrowhead Pharmaceuticals. I am Kevin Maki, and I'm the co-editor-in-chief of the Journal of Clinical Lipidology. And our topic today is Familial chylomicronemia syndrome. And I'm pleased to be joined by Dr. Archna Bajaj, who is going to answer questions about management of FCS. And so, Dr. Bajaj, maybe you can introduce yourself.
Great. Thanks, Kevin, and thanks for having me here today. So I'm Archna Bajaj. I'm a lipid specialist at the University of Pennsylvania, where I'm also an assistant professor in the Division of Translational Medicine and Human Genetics. I'm also the director of our clinical trials program and the preventive cardiology and lipid management program. So glad to be here.
Yep, you sound like a very busy person, and there's no way I would have remembered all of that. So thank you for that introduction. Maybe we can start with just when you see a patient who comes in with severe hypertriglyceridemia, how do you differentiate FCS from other forms of persistent chylomicronemia? And what lab testing do you do? And then how does that diagnosis change your management?
Sure. So maybe we can take a step back and think about severe hypertriglyceridemia a little broadly, and then how chylomicronemia syndromes are a subset of it. So severe hypertriglyceridemia, or SHTG, from a basic definition, is when you see triglyceride levels greater than 500. Now, when we talk about chylomicronemia syndromes, we're really thinking about the upper end of that range. So when we see triglyceride levels greater than the traditional cutoff that's used is 880 milligrams per deciliter. And then breaking that down even further. So thinking about chylomicronemia that can be caused from FCS, or familial chylomicronemia syndrome, which is the topic of today's conversation, but also multifactorial causes, such as which we're terming MCS, multifactorial chylomicronemia syndrome. So FCS is a subset of your chylomicronemia syndromes, which is a rare inherited condition due to genetic defects in the pathway of triglyceride metabolism, specifically genetic defects around the LPL enzyme and its cofactors. So the LPL enzyme is encoded by the LPL gene, and so your most common variants associated with FCS are those in the LPL gene, but there are also multiple cofactors that can be implicated in FCS. Multifactorial chylomicronemia syndrome is not necessarily that genetically, homozygous condition that's FCS, but it could be due to polygenic causes. So certain genetic and underlying genetic defects in triglyceride metabolism, plus secondary factors, which could be anything from diet, which can impact triglyceride levels, to medications, to other metabolic conditions. FCS I think of as your most severe category of patients with chylomicronemia syndrome, genetically driven, not necessarily due to secondary factors, I should say, but secondary factors might be present. Mm-hmm. And so when we're diagnosing FCS specifically, again, looking at triglyceride levels greater than 880. Persistence of triglyceride levels greater than 880 is a pattern. So if a patient presents with triglyceride levels sequentially or over time, showing many years this pattern of having triglyceride levels greater than 880 and into the thousands, that should give you a hint towards this patient might have FCS. And then second here is the high risk of acute pancreatitis in patients with FCS. So patients might come in describing previous episodes of acute pancreatitis, hospitalizations, or hospitalizations for abdominal pain. When you see the combination of those two, the severity, these severely elevated triglyceride levels, this history of abdominal pain or recurrent acute pancreatitis, that should clue you into a potential diagnosis of FCS, particularly when you ruled out the secondary factors that could be present in multifactorial chylomicronemia syndrome, like diabetes, metabolic conditions, and other medications.
And how much do you rely on genetic testing versus the new algorithm that we have for clinical identification of FCS?
Yeah, I always say, the clinical diagnosis trumps the genetics. Genetic testing can be helpful. It can be confirmatory when positive. However, genetic testing is not perfect. There can be variants that are missed. For example, also genetic testing isn't available or necessarily accessible for everyone. So you really should be making the diagnosis of chylomicronemia syndrome and certainly FCS based on clinical criteria. And we have scoring tools to help with that diagnosis. So, for example, the North American FCS score is one such tool. It's a scoring algorithm that allows you to take information like lab history of acute pancreatitis, presence of other secondary factors, and puts together a score, which you total up and will indicate whether you have likely FCS or not. So I think the scoring tools are very helpful, and that's really what I rely on in determining if a patient has FCS, and really using your clinical judgment based on the history that's presented to you.
And of course, for FCS, dietary management is an important component. And so it's a challenging diet to follow. So how do you help patients to adhere to the diet? What are the strategies that you use to help them achieve a very low-fat diet and maintain that over time?
Yeah, so this is a huge piece of FCS, right? So one of the things that can help make the diagnosis of FCS is that patients with FCS typically do not respond to traditional triglyceride-lowering therapies, such as fibrates or omega-3s or statins. And so diet is really, and traditionally has been paramount in treating patients with FCS. The treatment for FCS has traditionally been following a very, very low-fat diet, less than 20 grams of fat, which is very hard to follow for anyone who's done it. Anything higher than that, you're promoting formation of those chylomicron particles, right? And so really to maintain lower levels, an attempt to maintain lower levels of chylomicron particle formation, you want to follow an extremely low-fat diet. This is challenging to adhere to, right? These patients need to adhere to this diet day in and day out, 24/7, right? If you slip, if you cheat, one wrong meal can lead to an acute pancreatitis attack. And you hear this from patients. I've had patients who describe like, oh, I ended up in the hospital last week because I went out, celebrated a birthday, and ended up having some pizza. And unfortunately, it was just that one instance of not following such a strict diet that led them to having a hospitalization with acute pancreatitis. So it's a challenge to follow because of the requirement that you need to follow it so consistently. Otherwise, you will feel sick. And these patients have a really hard time following it, as you can imagine, through childhood, through adulthood, through birthdays, through celebrations. It causes, I think, a lot of stress, a lot of challenges, like how to manage situations with family and friends, and even just going out to eat is not so simple.
And historically, this has been a very challenging condition because a very difficult diet to follow, lack of responsiveness or minimal responsiveness to other therapies. But recently, we've had 2 ApoC3 target drugs that have been approved for management of FCS. And so how has that changed the landscape and your management of patients?
Sure. And I think anyone who has been treating FCS patients over the years realizes how huge the development of these treatments are. We've gone from having essentially no good therapy for FCS, right? So traditionally it was, we can try to use medications like fibrates for these patients, but you were not seeing an effectiveness. We can try to talk to them and counsel them through the diet, but we're still seeing patients with repeat episodes of acute pancreatitis. And there has really not been an effective therapy for these patients until, as you just mentioned recently, where we see development of these 2 ApoC3 targeted therapies, olezarsen and plozasiran. Olezarsen is an antisense oligonucleotide that targets the mRNA for ApoC3, and plozasiran is an siRNA that targets the mRNA for ApoC3. So both essentially shut down production of that ApoC3 protein and leads to increased metabolism of triglyceride and chylomicron clearance by doing so. So, we can walk through the data a little bit for both of these drugs and just to highlight how effective these therapies are in managing, again, a condition that historically we have not been able to treat effectively. So, olezarsen was studied in a trial of genetically confirmed FCS patients. Patients were randomized to olezarsen versus placebo. And by the 6-month mark, olezarsen showed over a 40% reduction in triglyceride levels. Again, keep in mind, this is a patient population that historically was seeing minimal reduction to fibrates and omega-3s. Plozasiran, similarly, in the Palisade trial for patients with clinically and genetically confirmed FCS patients, showing an over almost an 80% reduction in triglyceride levels for these FCS patients. That's huge, right? We're talking about a patient population that prior to these therapies, I think, I'd be optimistic to say we were seeing even a 20% reduction from the traditional triglyceride lowering therapies. And now we have 2 drugs, one offering a 40% reduction, one offering an 80% reduction based on clinical trials. Obviously, we need to see how these play out in the real world for effectiveness of triglyceride lowering, but very effective.
And I think even more important than the triglyceride reduction is in both of those trials, there were reductions in acute pancreatitis episodes.
Right. So this is huge, right?
Yep.
We've never had a trial before show a reduction in disease events in these patients. Again, I can't stress enough that acute pancreatitis is the primary cause of the higher rates of morbidity and mortality that we see in patients with FCS. And not only with your first episode of acute pancreatitis, but once FCS patients have that first episode, they're at even higher risk for having a second episode of acute pancreatitis. For anyone who's treated patients with acute pancreatitis of any cause, you know it's a severe condition. These patients might end up in the ICU because of the acute pancreatitis episode. Patients get very sick. Needless to say, they're at home suffering from nausea, vomiting, severe abdominal pain, even leading up to that hospital episode of acute pancreatitis. And that's correct. So both trials for olezarsen and plozasiran showed reductions in acute pancreatitis events. The plozasiran trial was a little larger and showed statistical significance in reducing acute pancreatitis events with plozasiran treatment. But again, this is the first time that we've seen now, with 2 therapies, a reduction in acute pancreatitis events. And I can't stress enough that this is a landmark innovation in the treatment for FCS.
It absolutely is. So having worked in running clinical trials for drug development for decades, the position of the FDA was you don't need to show a reduction in pancreatitis because we just don't think it's going to be practical to have a trial to do that. And now we have multiple trials that have shown that.
Right.
And so it's really a game changer from the standpoint of where we were a few years ago compared to where we are today. Now, a group with particular concerns would be, several groups, concerns around pediatric patients who have special challenges, concerns around pregnancy in women of childbearing potential with FCS. So how do you counsel for both of those, pediatric patients and then with potential pregnancy or actual pregnancy?
Sure. So I will say I treat only adult patients, so I don't manage the pediatric population. We do have a wonderful lipid clinic with our children's hospital in Philadelphia who follow the pediatric patients. It's incredibly challenging, right? So one of my patients was diagnosed with FCS at the age of 3 months with his first episode of acute pancreatitis. So again, I can't, I can't stress enough the severity of this condition. And he's had multiple pancreatitis episodes since then. He's now in his 30s, over 20 episodes of acute pancreatitis. But, first episode as a child. So, even as an infant and even going into the pediatrics, again, thinking about the limitations of the traditional triglyceride-lowering therapies and the importance of following such a strict diet in that population. As you can imagine, for a child to follow an extremely low-fat diet, can't go out and just eat with your friends after school or during school, right? You have to follow a very special diet. And that's so challenging for kids to follow. And you can imagine really hard to just fit into certain social situations or just be at school or go to birthday parties. So really a challenging lifelong chronic condition that needs to be managed. The 2 drugs we just spoke of, the ApoC3 therapies, are indicated in adults for FCS. So I think hopefully we'll see this move towards the pediatric population in the future once we have more data and more studies there. But as of right now, it is not indicated for the pediatric population. Pregnancy also an interesting case, right? So for any lipid specialists out there, that triglyceride levels rise in pregnancy for any healthy adult, right? Not even considering the population where you have underlying triglyceride metabolic abnormalities, but just part of pregnancy, triglyceride levels rise through the second and through the third trimester. The rises are more extreme in patients with FCS or in patients with triglyceride conditions, right? You're going to be constantly worried of sure, maybe they start the pregnancy with triglyceride levels controlled as you get it. But at some point during the pregnancy, with those hormones shifting, are you going to see levels rise, which is going to trigger an episode of acute pancreatitis? One of my patients was diagnosed with FCS during her first pregnancy when she presented with acute pancreatitis. So that rise during pregnancy is real and something to be concerned about. We have in our program, so not myself personally, but my colleague, Dan Soffer, I remember he's talked to me about a patient with FCS that he treated with plasma exchange to get her through pregnancy, right? And so that is sometimes a method that we need to utilize in patients where obviously using some of these drug therapies in pregnancy will be limited. But plasma exchange, limited effectiveness, right? So brings down the triglycerides rapidly that instant, but they're going to climb back up. And I remember he was doing plasma exchange once or twice a week for the patient and monitoring triglyceride levels very closely to try to get them through pregnancy. So a very challenging situation to manage.
Definitely. Now, in most patients who are not pregnant, what do you do in terms of monitoring of those patients for side effects, control of their triglyceride and chylomicron levels, and general monitoring to make sure that they're staying on course and keeping the level of triglycerides down low enough to avoid high enough chylomicronemia to produce pancreatitis?
Sure. Yeah. So these are patients you should follow closely. They are rare patients, and they're the patients that, in our lipid program, we spend more time with. It's just these are visits that are going to require more time. You really should be dedicating enough time to counsel the patients appropriately and really support them. This is again, a challenging chronic condition. I think per guidelines, even the recommendation is that you're following and tracking those triglycerides once every 3 months or so, right? Just to get a sense of where their triglyceride levels are and trying to catch if it's rising or falling. But triglycerides vary and fluctuate rapidly too. And so part of the reason for having frequent visits with these patients is to remind them of staying adherent to a low-fat diet, because again, one wrong meal can double, triple their triglyceride levels and put them into that range where acute pancreatitis could occur. So I think there is a need for just constant, I shouldn't say constant, but for close follow-up and close communication. These are potentially very sick patients if things are not followed appropriately, right? You don't want to have these patients end up in the hospital with acute pancreatitis. That's what you're trying to avoid. So frequent lab follow-up, which also gives the patient feedback in terms of how their triglyceride levels are doing. They should be aware of it. They should also be tracking it so that they know that they have some control over it with their diet too. Seeing them in the office, these are patients you should be seeing quarterly. They should be plugged in with a dietitian to answer those questions. And then with, the new therapies that we spoke of, obviously the counseling around starting new treatments, monitoring lab work once every 3 months, especially in the beginning when you're first starting them on the medication therapy, and just, again, following those trends and those triglyceride levels and trying to catch any patterns.
You mentioned a dietitian. In my experience, I don't have much experience actually with patients who have FCS, but we've run many clinical trials in severe hypertriglyceridemia. And so in my experience, a dietitian is really critical. And Jamie Underberg, who's past president of the NLA, said something yesterday that I thought was really interesting. The patient may know what to do, but the dietitian helps them with how to do it. And so I just wonder if you would comment on how you utilize dietitians.
I also want to point out that not all dietitians are trained the same. Not the patient might say they met and saw a dietitian somewhere. That doesn't mean that dietitian is knowledgeable about FCS. So it's really important as a clinician to be able to offer the resources of a dietitian who is knowledgeable specifically about FCS. As you can imagine, again, the diet recommendations for FCS are a very low-fat diet. It is not the same diet recommendations that you can just blankly give out to patients for a quote-unquote heart-healthy diet or a diabetes-friendly diet, right? This is a very specific diet. And so the dietitian needs to be able to walk them through that. So we have a dietitian with our clinic, Fran Burke. She's fantastic. She's been with our program for a long time and has worked with FCS patients. And she will walk them through meal plans and count how many grams of fat does each of these items bring into your meal. I know she also talks patients with using MCT oils, so medium chain triglyceride oils, because that is not going to promote formation of those chylomicrons, and teaching them how to use MCT oils because it's not easy to use or to cook with, but doing the proper counseling so that they are aware of, you're not just telling them, okay, you're eating X grams of fat. No, tell them specifically what is their breakfast, what are good breakfast options, what are good lunch options, what are good dinner options. When they go out to eat, what can they eat off of a menu so that they're still able to live their lives? So I think really important to have a dietitian that you can connect with and connect your patients with who are knowledgeable about FCS and the resource. There are a lot of resources out there. I think the NLA has some resources for patients too to help them with the diet recommendations.
Right. I think the NLA Foundation on the website has some resources for patients that are really useful. And I want to just emphasize a point you made, which is that not all dietitians have training in management of FCS. So it really needs to be a dietitian who has that specific training and experience. So with that, are there any other items you'd like to mention with regard to management of FCS?
Yeah, I think the treatments, it's rapidly evolving, right?
Yes.
What we did a couple of years ago is all of a sudden not the same as what we're doing now. And that's thanks to the new therapies that have been developed, the ApoC3 targeted therapies. So, I think with the introduction of olezarsen and plozasiran into the clinic, I think our conversation with the patient has changed. It's become more optimistic, which is great for the patients, that we can actually walk into a clinic appointment and have a treatment that we know is going to be effective. I think it's great that we have two treatment options. It's always good to have options. If for some reason the patient prefers one over the other or, tolerability differences, I think it's great that we have now two options. We went from 0 to 2, which is huge. And so I think our conversations with patients have changed. I think it's now more a sense of we can actually treat this and control this, whereas I think our hands were tied a few years ago. Really, by the time you're reaching for things like plasma exchange and having a discussion, that's a little bit more of a desperate measure compared to the options that we have available.
Yes, and I know many lipidologists who expressed severe frustration with FCS and trying to manage these patients who keep coming back with acute pancreatitis. And it is a much more optimistic time now because there are treatments available that have been demonstrated to reduce acute pancreatitis risk. So it is a new era and things are continuing to evolve. So thank you so much for spending time to talk with us about FCS. And we hope you enjoy the meeting this weekend.
Great. Thanks for having me, Kevin.